Hi everyone, this is Margarita, and today is my honor to introduce Brooke coming to us today. We are actually going to recording our podcast today, but before that, we will let Brooke have a presentation to show us about what she does. Brooke,
Thank you. Thank you for having me.
yes.
Okay. My name is Brooke Conkin, as Margarita said. I am a pelvic floor physical therapist, and I've been a pelvic floor physical therapist now for 16 years. Um, I own Conkin Pelvic Health in Edmond, Oklahoma, and I opened that about a year and a half ago. But I've been doing this again for about 16 years. So lots of experience in the pelvic health realm. Today I'm going to talk a little bit about your pelvic health, what pelvic floor physical therapy is, and how it can help pelvic floor dysfunction. So first we'll talk about pelvic floor, and the pelvic floor is at the bottom. It's a bunch of muscles at the bottom of your pelvis. So it creates a sling or a bowl to help support your pelvis, working with other core muscles. So it is part of your core. So it works with your back muscles, your abdominal muscles, your diaphragm, which is at the bottom of your lungs, all to support your core or support your spine and your pelvis. It also helps with maintaining continence, so keeping you from peeing or pooping your pants. It provides support for abdominal and pelvic organs, since it's at the bottom of your pelvis. It provides stability and postural control. The superficial muscles and some of the deeper muscles also are involved in sexual function and also circulation. So it helps kind of pump that blood back up to your thorax area. So it's kind of like a sump pump. It also helps in birthing and labor. It has to relax in order to give birth. And then it helps with breathing and intra-abdominal pressure regulation. So your pelvic floor and your diaphragm work together like a piston. So diaphragm here, when you take a nice deep breath in, your diaphragm flattens, your pelvic floor relaxes and lengthens. And so it kind of works like a piston to help regulate that intra-abdominal pressure. So what causes pelvic floor dysfunction? That can be many different things. Pregnancy is a big one, and we'll talk more about that later. But postural changes, hormone changes in pregnancy, and that increased load on your pelvic floor can cause pelvic floor dysfunction. Hormone changes with puberty, with perimenopause and menopause, along with pregnancy as well, can cause pelvic floor dysfunction. Trauma or injury to the pelvis, spine, pelvic floor, hips, that can cause pelvic floor dysfunction as well. Guarding, so kind of holding yourself because you're either in pain or you're trying to stabilize your pelvis or spine or hips due to injuries in delivery, or if you've had surgery, or different medical conditions like hypermobility syndromes. Those things can also cause guarding and cause increased tension in the pelvic floor, typically. Lack of pressure regulation with like lifting or exercise, so like holding your breath or pushing down into your pelvic floor, that can cause pelvic floor laxity. It can also cause pelvic floor tension if you are constantly trying to hold against that increased pressure. So it can go either way there. Chronic constipation or straining, that can put pressure down on your pelvic floor. Chronic coughing can put pressure down on your pelvic floor and cause weakness there. And then stress or anxiety or nervous system dysregulation typically causes pelvic floor tension. So what are some symptoms of pelvic floor dysfunction? So incontinence is a big one. So urinary loss of control of urine or feces as well. Pelvic pain, so pain with intimacy, pain with using a tampon, pain with like a pap smear or pelvic exam, yearly pelvic exam. Pelvic pressure or feeling of organs falling out, so that would indicate maybe a prolapse. So that usually goes along with pelvic floor weakness. It can go along with pelvic floor tension as well, but just a lot of pressure in the pelvis and then even feeling like something might be falling out, that's an indication of prolapse. Again, constipation or straining can be a sign of pelvic floor dysfunction with not being able to empty. So having to push a lot, that can indicate some pelvic floor tension, not being able to relax your muscles to have a bowel movement. Inability to fully empty your bladder or bowel. So you need to be able to relax your pelvic floor muscles to empty your bladder or bowel. A lot of people think you use them to push those things out, but you actually have to relax those muscles in order to empty. And then any type of chronic hip, SI joint pain, lumbar pain, back pain, tailbone pain, groin pain, anything in this area that is lingering pain could be due to pelvic floor dysfunction. If you have tried like chiropractic or massage or injections or anything, things like that, and typical regular physical therapy as well, like orthopedic physical therapy, and those things are not helping, you can definitely look at your pelvic floor to see if that might be contributing factor as well, because a lot of those treatments don't actually look at the pelvic floor specifically. There is a dysfunction screening protocol called the Conkin pelvic dysfunction screening protocol, and it gives you a bunch of questions. And if you answer 3 or more yes, then you may have pelvic floor dysfunction. You may want to speak to a pelvic floor therapist. So what do we do to help pelvic floor dysfunction in pelvic floor physical therapy? So the first thing we do is do an initial evaluation, which consists of doing kind of an interview, so asking you a lot of questions, discussing your symptoms, your medical history, your limitations, and your goals. And then we do a musculoskeletal screening, so looking at strength, range of motion, posture, pelvic alignment, balance, flexibility, areas of tension, functional movements like squatting or straight leg raising, just to see how your core responds to those things, and if there's any coordination issues with pelvic floor and your other core muscles. Then we do a pelvic floor assessment typically. Now this can be tailored to the person's comfort level. So if you are not comfortable doing a pelvic floor assessment, we can kind of work around that. We can do that later and kind of get you warmed up to it, or if you just don't want to ever do it, we can kind of work around it. But to look at your pelvic floor fully, it's typically we do an external observation, so looking at how your pelvic floor moves, if you can relax your pelvic floor, contract your pelvic floor, what it does when you cough, what it does when you take a deep breath, that type of thing, and how it works, how it coordinates with your deep abdominal muscles. So we test that. So we observe first. So that requires kind of so you undress from the waist down, cover up with a sheet, and then we just do an observation. And then we do an internal exam typically, again, depending on comfort level, but that is an internal exam to assess strength, to assess ability to relax, endurance, coordination, again, with your other core muscles. We also look at sensation and scar tissue mobility, and if there's any nerve involvement as well. And then we also look for prolapse as well, test for that. So depending on what we find, we tailor a individualized treatment plan for each patient, and that can include many different things. So it's not a cookie cutter like protocol for, say, if you have incontinence. I don't do the same thing with every person that has incontinence, or the same thing with everybody that has prolapse. It's tailored to each patient, so depending on what we find. So it can include manual therapy, which is like soft tissue mobilization, myofascial release, visceral mobilization, which is moving the organs, mobilizing the organs, and joint mobilization. And then we do a lot of bowel and bladder retraining. We do therapeutic exercise, so pelvic floor muscle training, so strengthening or relaxing those muscles depending on what you need. Core strengthening, total functional pelvic floor strengthening. So it's not just strengthening the pelvic floor. It's not just doing Kegels. It's coordinating those muscles with your other core muscles. Doing a lot of stretching, mobility, and then posture training, body mechanics, and pressure management. So again, we talked about that kind of piston movement of the diaphragm and the pelvic floor. And we train how to lift and how to exercise and how to breathe to manage that pressure, to prevent anything like prolapse or weakening of those pelvic floor muscles. We teach a lot of diet modification, lifestyle habits, fluid intake, that type of thing, and then relaxation techniques as well. So a lot of pelvic floor dysfunction can come from nervous system dysregulation. So we do a lot of like vagus nerve stimulation to increase parasympathetic nervous system, and then decrease or downregulate the sympathetic nervous system. And then we use biofeedback, which is basically it's sensing the muscle activity, the electrical activity in your muscles. So we can use that to show the patient how well they're contracting their muscles, how well they're relaxing their muscles, and how well they're coordinating their muscles with their other core muscles. We can do electrical stimulation to help strengthen the pelvic floor muscles. And then we can use TENS or transcutaneous tibial nerve stimulation for, and that goes on your tibia through here, for urinary overactive bladder, urinary frequency type symptoms as well. So there's a lot that can be involved in the treatment plan. And typically I see people, depending on what we find and what their diagnosis is and how long they've been dealing with the issues, but typically I see patients anywhere from 4 visits, sometimes 2 visits, but 4 visits to 12 visits. That's the typical range. But sometimes I see people longer, and it's typically once a week in the beginning, and then we can taper off as symptoms resolve and as things improve. But that is the typical timeline of treatment plan in pelvic floor physical therapy.